colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie Dialyse et Transplantation, Marcus at Home welcomes Professor Maurice Brown in London, United Kingdom, with whom we would like to discuss, firstly, the diagnosis and treatment of primary hyperaldosteronism, and secondly, and somewhat overlapping, novel therapeutic approaches in resistant hypertension. Dear Professor Brown, dear Maurice, thanks so much for taking the time. Thanks so much for being our guest tonight.
It's my pleasure.
Dr. Maurice Brown is Professor of Endocrine Hypertension at the Queen Mary University of London and the William Harvey Heart Centre, again in London, UK, and past president of the British Hypertension Society. During more than 4 decades of laboratory and clinical research on the pathogenesis and treatment of hypertension, he has published countless seminal papers in the field, with more than 20 publications in the New England Journal and Lancet alone. He has conducted landmark studies on antihypertensive treatment, including Pathway 1, 2, and 3, Time, Brighton, Insight, and Accelerate, to name just a few. A further major focus of his clinical and academic work are studies on the most common cause of secondary hypertension, which is primary hyperaldosteronism, which may revolutionize the way we detect and treat affected patients in the future.
Thank you very much for asking me. And I thought I would start with a few slides on how we currently diagnose and treat hyperaldosteronism and what we are doing to try and modernize some of that. I have one disclosure I should start with, which is that I was a member of the Scientific Advisory Board of SYNCHOR, and they have now been taken over by AstraZeneca. So next year will be the 70th anniversary of the discovery of the first patient with what became called Conn's syndrome. And because of the limitations of the technologies of the time, this patient turns out to have a rather extreme phenotype, both biochemically and size of a tumor. And to a degree, that put doctors off the scent of the much commoner type of primary aldosteronism for following decades. And in part, that also led to a rather arduous course before one can diagnose the patient and then find out whether the patient has unilateral or bilateral aldosteronism, with the unilateral type being the subtype that can be cured by surgery. So I'm not going to go through the 10 hurdles that I've shown here, but I might mention that it's difficult at the start because of the need to withdraw interfering treatment before diagnostic tests are undertaken. And even at the end of the hurdle race, it's a toss of a coin before we know which patients are going to be completely cured of their hypertension by surgical treatment. So that hurdle race is a view of what the current guidelines for treatment of primary aldo teaches us. And I will briefly go through what we should currently be doing and then suggest some possible changes. This is the key algorithm in the guideline with multiple steps. And it is true that if you begin at the beginning, screening all patients at increased risk, and end at the end, removing the unilateral cause of hyperaldosteronism, most patients with primary aldosteronism would be diagnosed and effectively treated. But currently, fewer than 1% of such patients are found and diagnosed and treated. To simplify this diagram a little, I've drawn a line between the first part, which looks at diagnosing primary aldosteronism itself, and the second part, which looks at subtyping into unilateral and bilateral disease. And for the diagnosis itself, there are 2 ways of doing this. Either the patient has what I call the trilogy of high aldosterone, low potassium, and suppressed renin, or if any of those are missing, the patient needs to have one of 4 suggested confirmatory tests. And then in the second part, which is to do with subtyping and then treatment, the available test is an invasive test called adrenal vein sampling, which very few centers can do. And it leads us to a surgical treatment, which maybe was appropriate when Con syndrome was a curiosity, but in the absence of long-term data showing efficacy, it's more doubtful whether surgery can be justified as a treatment for a condition we now know to be the cause of between 5 and 13% of all hypertension. So before leaving this, I just want to add a couple of suggestions for making the guideline more practically applicable. One is to focus on patients with high sodium levels and low potassium levels, even when these aren't actually outside the normal range. And the second is to be less concerned about drugs interfering with measurements, with the only serious interfering drug being beta blockers, which work by blocking release of renin. So the rest of what I'm going to say is about the patients below the line in whom the diagnosis has been made, where we're interested in trying to find a unilateral cause and cure it. And in terms of what we currently do, conventional management has scarcely changed in the last 30 years, and much of it not in the last 50 years. But alongside this unchanging practice in the clinic, the last decade or so has been an exciting time in our molecular understanding of primary aldosteronism. And I will be saying a little bit about new tests which allow us to image the adenoma, to study the adenoma immunohistochemically after it's removed, and to understand what's causing it by looking for somatic mutations in the tumor. And this is not now just scientific curiosity, but allows us to begin to change our practice. And the changes which I will illustrate are molecular imaging or PET-CT, ablating the individual nodules rather than removing the whole adrenal, using tests based on our understanding of genotype for predicting which patients can be completely cured of hypertension by removing the adrenal, and then trying to get away from any intervention by developing new treatments which will inhibit aldosterone production by the tumor. So the PET-CT scan that we developed uses an old veterinary anesthetic called carbon-11 metomidate, and ex vivo, it is a non-selective inhibitor of the enzymes which make aldosterone or cortisol. But in the patient pre-treated with 3 days of dexamethasone, this example shows a patient who on the coronal CT, you can see there's a lower and upper adenoma. Only the lower adenoma is hot. And when we look at the axials through those two levels, you can see the upper adenoma cold, lower adenoma very hot. And this corresponds to what we find after the gland is removed, that the tumor at the top does not express any of the enzyme CYP11B2 or aldosterone synthase, but a little of the enzyme making cortisol or CYP11B1. Whereas the tumor at the bottom, which is hot on the scan, stains densely for the enzyme making aldosterone and only a little bit for the enzyme making cortisol. So this sort of patient assures us that our dexamethasone pre-treatment renders carbon-11 metomidate a highly selective ligand for the enzyme making aldosterone. We've recently published a trial in Nature Medicine in which all patients had both investigations, and that allowed us, if I just summarize what we found, to say that metomidate, carbon-11 metomidate, is at least as good as, non-inferior in the technical jargon, to adrenal vein sampling in detecting unilateral primary aldosteronism. One of the secondary objectives of this study, which is a rare prospective trial in primary aldosteronism, was to look at which patients are completely cured. And the trial itself showed that only 30% of patients, even those positive by both adrenal vein sampling and metomidate PET-CT, come off all treatment and have a normal blood pressure. And it turns out that the genotype of the tumor is the best predictor of outcome. In this slide here, we see the number of patients in whom each of the 6 genes in which somatic mutations have been found by us or others were present. And it's apparent that there are 2 most commonly mutated genes, a potassium channel KTNJ5, first reported in 2011, and a calcium channel will be reported in 2013, with a very striking ethnic variation that the black patients mainly have the calcium channel mutation, and the white and Asian patients more likely to have the KCNJ5. So the question which James did ask was whether the difference in these would predict patients who are completely cured of hypertension. So here I've replotted the data, only showing the number of mutations in patients who are completely cured, and it's apparently that it's really only the KCNJ5 mutant patients who are left standing. And on a logistic regression analysis, the genotype of the tumor trumps all other variables. Now, this is not just a scientific curiosity, because in the same trial, we validated a surrogate measure for genotype, so-called hybrid steroids, that a number of investigators had shown are only secreted by cells which make both cortisol and aldosterone. And when we plot the ratio of the hybrid steroid to cortisol against genotype, you can see there's almost clear blue water between the high levels in those with the KCNJ5 genotype and other patients. So in the future, and we are going to test this again in our current prospective trial, we think that the measurement of hybrid steroids will predict patients who can be completely cured of hypertension by surgery. But the carbon-11 metomidate has one limitation, which is it has a 20-minute half-life and has to be used in hospitals with an on-site cyclotron. So in the same study, we also validated an 18-fluoro analog, more recently developed by colleagues in Uppsala and Cambridge. And I've shown two examples, one with a large tumor, one with a small tumor. And in each case, you can see that the metomidate and CETO images look virtually identical. And in an analysis of all 31 patients who had both scans, you can see in the orange bar of the column, those who were high probability of unilateral disease, there was only one patient who didn't have the same result by both scans. So we've now started using this 18-fluoro analog, which is made in Cambridge and delivered to us at St. Bartholomew's Hospital, and other hospitals around the land can shortly follow. I'm turning for the final part of this presentation to newer treatments. And the first is linked to the PET-CT, because the PET-CT also showed us that on the left-hand side, the adrenal is very close to the stomach, something not always so obvious on the axial view where the pancreas can seem to intervene. And that opened up the possibility of ablating the left side nodules through the endoscope with an ultrasound probe in the stomach, visualizing the adenoma. And this adenoma is only a centimeter or so away from the ultrasound probe. And my next slide illustrates the ablation. A number of burns with the catheter in different places are undertaken, which maximizes the safety of the procedure, avoids stimulation of the adrenal medulla. And you can see this white appearance developing, which is the infarcting tumor during the course of a 10 to 20% burn. So the whole procedure is over in 5 to 10 minutes, and it's very exciting when the patients where the ablation is complete are cured of their hypertension. And here's one example, a patient with a hot adenoma before the ablation completely disappeared afterwards. And by doing fine needle aspiration of the tumor before ablation, we can prove that what we've ablated is something that is positive for the aldosterone-synthesis of 11B2 and weak or negative for the enzyme making cortisol. So I might sum up here and say that for the KCNJ5 mutant patients predicted by hybrid steroids, surgery may remain an attractive option in the future, delivering complete cure. But for everyone else, medical treatment and maybe radiofrequency ablation, if validated by larger studies, will be the treatment of choice. Of course, we need a trial, and we're now about a quarter of the way through a head-to-head comparison, 110 patients, half having surgery and half radiofrequency ablation. But medical treatment would clearly be more attractive than any intervention. For years, we've had spironolactone, and doubtless we'll talk about that in a moment. But of excitement is the development of a new class of drugs that works by inhibiting the production of aldosterone. And the challenge over the years has been that the enzyme making aldosterone is very similar in structure, 93% identical to the one making cortisol. And it's only in the last few years that drugs have been developed that are sufficiently selective to inhibit one without the other. And my last couple of slides are from a phase 2 trial we published earlier this year, showing that baxdrostat, the first of these highly selective inhibitors, is an effective treatment in patients with resistant hypertension, a condition which I and I think several others would regard as effectively being primary aldosteronism until proven otherwise. So in this trial, 240 patients had placebo or one of 3 doses of baxdrostat with an active treatment period of 12 weeks. And the results show a placebo-corrected fall in systolic blood pressure at the highest dose of 11 millimeters, which is very similar to what we previously showed with spironolactone in our Pathway 2 trial. And there's the diastolic pressure data. So to sum up, over the course of the decades since the discovery of Conn syndrome 70 years ago, we are able to find ever smaller tumors, but the conventional methods for the process have not changed. But newer methods are available, and I briefly talked about PET-CT, endoscopic ablation, looking for the tumors which are most likely to be cured by surgery, and briefly introduced to aldosterone synthase inhibitors. Lots of people, of course, have taken part in the work that I've described to you. And here's a picture of some of us at one of our summer parties. I'd like to pay special tribute to Xilin Wu, who was the first author of the Nature Medicine paper, Lina Azizan, who helped us discover many of the somatic mutations, and my clinical colleague, Will Drake and Mark Annell in Cambridge. Thank you.
So thank you very much, Professor Morris, for this fascinating and surely eye-opening talk that you just gave. I think we have many questions. Maybe I can start. The adrenal venous sampling is indeed a challenge, at least in the whole country, Austria. There's not a single center who has a large volume of patients where an experienced physician can do this analysis. So we have the diagnosis and we often cannot refer. We send them to Germany and some centers there. Do you think that what you just have published in Nature Medicine, that a PET-CT could be the substitute in the near future for this venous sampling?
Well, I'm confident that what we've shown in the study and the follow-up with the 18-fluoro analog provides an accurate alternative. And the question now is how soon that PET-CT ligand can be rolled out to be delivered to hospitals such as yours in Austria. Mm-hmm. There is no reason in principle why an 18-fluoro ligand with 2-hour half-life cannot be made in one country and sent to hospitals in another, and that happens every day of the week with FDG, which has the same 2-hour half-life. So it's a matter of finding probably a commercial supplier who will take this on, or else an academic center in, if not every country, at least some countries, who are interested in the delivery. So yes, I think the answer is yes, but we're not yet at the full implementation stage.
So in your center, venous sampling is history now?
That's not, in fact, what's happened. As you know, changes take place slowly in medicine. And also, as the results in our match study showed, there are still some patients who are only positive on one or other technique. And the PET-CT is definitely preferred for the patients where the CT or MRI has shown an adenoma, but would be less useful if you suspect unilateral disease without a definite adenoma. So I don't think we'll be bearing it quite yet.
So we largely come from nephrology, and we several years ago we became aware of that chronic kidney disease patients can be affected by hyperaldosteronism, and then we were very sensitive and applied tests in many patients, and somehow a little bit exaggerated, we thought in our center it's a kind of epidemic. We see so many patients, And I think there's still a lack of how to treat them when the kidney is affected, because the glomerular filtration rate goes down. Then there you see a progression of kidney disease when they are treated and so on. But regarding the tests, also for the extramural testing, some advocates just do the aldosterone-renin ratio independent of what they are taking, because the threshold is somehow arbitrary, just to find them. Do you think this is true? Should we do the test deliberately?
So I do think there's scope for being more pragmatic, and that one of the reasons for the very low diagnosis rate, as I said, less than 1%, is that it all looks too hard for many physicians ever to get started on that hurdle race. And the main interfering drug is beta blockade, and in the UK, that's largely dropped out of first, second, or third line use in hypertension. And I feel that in patients whose main drugs are a RAS inhibitor and calcium blocker, even a thiazide diuretic, none of those are going to stop you from diagnosing a true case of primary aldosteronism. And if anything, if the renin remains suppressed, which is the main driver of the aldosterone-renin ratio, if the renin is suppressed despite being on a RAS inhibitor, then you're even more likely to have primary aldo than when the renin's low off all treatment. So I'm broadly with you in encouraging a more pragmatic response. Ironically, when we do our research trials, we don't want to embark on 4 years of work and then have reviewers tell us, oh, but your patients didn't have primary aldo. So in MATCH, we were whiter than white and followed the rule book to the nth t, only to be greeted by reviewers who said, this is artificial. Most patients are not so strictly diagnosed in the real world. So for our next trial, we're not being quite so strict with ourselves.
And still, then a confirmatory test such as salt loading is a requirement, you think?
So I would reduce it to saline infusion or captopril. And of those two, I find that endocrinologists still broadly prefer the saline infusion, whereas those of us like myself who come more from a hypertension background prefer the captopril test, because especially in resistant hypertension, we worry about taking patients off drugs which may be necessary for a reasonable blood pressure control. And the captopril test probably gives you twice as much for your money, in the sense that, as I just said, if your renin stays suppressed throughout the test, despite having the ACE inhibitor, and the aldo does not suppress, then you can be pretty confident the patient truly has primary aldo.
Maybe finally, a nephrology-specific questions. I was impressed that we had 3 patients born in the 90s coming to the emergency department with a systolic blood pressure of 250, hypokalemic and largely damaged kidneys with a creatinine of 5.6. And then we couldn't substantiate that they had a primary hyperaldo. Is it possible that due to ischemic kidney injury, the renin, there's a leakage and therefore renin may be high?
Yeah, that's a good question. And there's been a number of papers on the subject of normoreninemic primary aldosteronism. And I too have had patients like that. It does make it more difficult to make the diagnosis, and a confirmatory test would be required. The view is not so much that those patients can't have primary aldo. I think the conservatism is driven by that hurdle race and knowing what the patient has to go through to be diagnosed and treated. There's anxiety about letting patients start who statistically you might say are a bit less likely to have the diagnosis than if they fit the trilogy from the start. But I agree. I think an important message is there are so many thresholds for making the diagnosis that one has to be flexible and regard these as guidelines, thresholds. There are exceptions to all of them. And in the presence of someone who's had hypokalemia, especially hypokalemia of the sodium over 140, I would be very suspicious of the diagnosis of primary aldo.
So I will speak with my nuclear medicine guy that we get the tracer.
Well done.
If I may, thanks a lot for your great work and for this presentation. I'd like to start with a very practical question, building on what you were discussing with Marcus. We quite frequently see abnormal aldosterone-renin ratios, but not enough elevated aldosterone to meet the diagnostic criterion. I, of course, understand you say these are not one single specific diagnostic criterion to follow, but how do you follow these patients who do not meet the criteria for the diagnosis, even after the confirmatory test? Do you rule out the diagnosis, or do you follow them for years and see, well, a few years later, they will probably have primary aldo? How do you follow these patients?
So again, a very key question. And I can tell you what I might do now and what is coming up quite fast on the horizon. So once again, if the clinical or biochemical suspicion is high, but they're not meeting the threshold, then you have a medical and surgical option. You want to know whether it'd be appropriate. You want to know whether the patient might do better on spironolactone or another alternative, my current drugs. And realistically, if you're not controlling the hypertension with conventional drugs, and some but not all pointers are towards primary aldosteronism, you're going to give them a trial of medical treatment. When it comes to considering whether there might be an option for surgical treatment, I probably have a lower index for proceeding to do a CT scan of the adrenals. And if you and the patient think that removing the adrenal might be attractive if they were found to have unilateral disease, I wouldn't be put off doing a CT, because not everything is fitting what the guideline says. What I think is going to make this a bit less hit and miss is the use of urine, 24-hour urine, maybe overnight urine, aldosterone. And this was sparked partly by a paper from Boston in 2020, Annals of Internal Medicine, by Anand Vadya's group, showing that maybe the true prevalence of primary aldo would be doubled if we used urinary aldo rather than blood aldo. And that was followed by recognition how variable blood aldosterone, hence ARR measurements are. And since it coincided with one of our Nature Genetics papers where we found a particular gene to be mutated, cell adhesion molecule 1, that regulates biological clock genes in the adrenal, and the index case had a cyclical form of aldosteronism where most measurements were not diagnostic, but one was, we are suspicious that we are missing many patients whose levels of aldosterone are fluctuating. And we have a current research study where the research fellow, Dr. Yuni Lee, is collecting 24-hour urine, we're measuring tetrahydroaldosterone. And even on the first 20 patients, we can see that there are many subjects, like the ones you describe, where it takes multiple measurements to nail the diagnosis on a blood sample, but a single 24-hour urine is clearly above threshold. So there isn't enough evidence to say everyone should be having 24-hour urine aldo, and there isn't a routine assay available at the moment. But I know the group in Boston are optimistic that that's going to solve the problem you mentioned.
Okay, thanks. I have another diagnostic question, which is more seldom. You spoke about the somatic mutations in the tumor. What about the germline mutations? Which patients should be screened for germline mutations in genes that are prone to cause APA?
Yes. So germline mutations are very much less common, whereas the somatic mutations, the adrenal, probably some of the commonest in medicine. But some of the genes, such as casein J5 itself, can occur in the germline, and paradoxically was first recognized clinically as a familial problem 2 or 3 years before, by the same group, by Rick Lifton's group, before he found the somatic mutations in commonly in tumors. When he went back to the family and found they had it in the germline. Now, partly answering your question, the patients in the germline paper were 2 sisters in their teens, and the answer is that it's when primary aldo occurs at a very young age, younger than 20, if not even younger. Those patients should be screened for the germline mutations. Later on, I'm sure we miss a few, but it's sufficiently rare that I wouldn't recommend we routinely look for germline mutations in older patients.
We spoke to John Funder, I guess 2 years ago, who was the first author of the 2016 guidelines and who's very radical now, actually, in stating that we shouldn't measure aldosterone at all, and who suggests really now assays that are purely based upon renin. Do we already know when we will see a new guideline? Because all you experts now are openly, well, rather reluctant to apply the 2016 guidelines. So do we already have any news when the novel guidelines will come?
So that's a simple answer, because there's a new guideline committee in operation at the moment, and I'm not a member of it, but I think I probably know most of them, and they're hoping to bring a new guideline out early next year. So there will be a new one, and I hope it will be more pragmatic. The problem is the dearth of really good evidence, and that makes it more difficult to find a meeting of minds when there haven't been studies to resolve differences. I agree with John Funder. I think the idea of using renin is something maybe even arose in conversations between us, because when I was in Cambridge working mainly in a hypertension practice, I would probably be measuring renin in most of my patients, certainly the resistant hypertensives, and other patients not responding to a RAS inhibitor at a young age. And if the renin is completely suppressed, the ARR probably will be elevated, because the renin is the main driver. And as I was saying to Dominique, because I have a low threshold of getting a CT scan done, if I think a patient might be amenable for surgery, I might even request that while waiting for follow-up aldosterone. So I agree with John on that.
And I have a second question, Dominique, before switching back to you again. I have a problem in understanding one thing in this field. So we all believe that aldosterone is something that is not only raising our blood pressure, but also that is affecting our cardiomyocytes, our renal cells, so people get CKD and heart failure. How come that people who have a very low salt intake and who have very high aldosterone in reaction to this low salt intake are not affected by these cardiac and renal disease, like native people in some Asian islands? Do we have any good explanation for that?
Well, the usual answer is to state what you've nicely put as the fact, namely it's aldosterone plus salt, which is toxic to the cardiomyocytes and other cardiovascular tissues, whereas high aldosterone in the absence of excess salt, indeed in responding to low salt, is not cardiotoxic. Quite why or what the mechanism is for that level of tissue damage, I don't think is understood. I shelter a bit behind saying my interest has been very much more in release of aldo than the response to aldo questions. But we did have some nice data in the MATCH study where we did cardiac MR in a sub-study of 50 patients and measured BNP in most of the patients before and after. And very strikingly, the surgically treated patients had a much greater benefit at heart level, whether on the CMR or BNP, than did the medical group. And that may be one reason why we shouldn't necessarily be too sad that we're not curing patients completely of hypertension in larger numbers. It does look from the cardiac data that even if patients don't come off all their drugs, as well as the benefit of taking fewer drugs, which I'm not sure really justifies an operation, we are benefiting the heart. But I know this isn't the question you asked me, but I do think that there is a public health challenge, an issue, that we are doing major surgery without long-term evidence of benefit, which was fine in the days when Common syndrome was thought to affect fewer than 1% of patients, but is not fine at the currently accepted prevalence levels.
I followed some patients who lost their kidneys because of hyperaldo, and then they were transplanted and they didn't have any more hypertension. didn't need spironolactone, and I saw that the aldosterone acts via the calcineurin pathway, and all these transplant patients take calcineurin inhibitors. Are you aware that maybe despite having a pathological ARR, therefore the effect is, so to say, eliminated of aldosterone via taking calcineurin inhibitors?
I wasn't aware of that. It's very interesting.
Yeah.
I'm aware of the story of renal transplantation curing some types of hypertension. It probably wouldn't surprise me, because so many things are multifactorial. The level of hypertension achieved in a primary aldo patient, we concentrate on the aldosterone levels and its hypersecretion, but it evidently is affected as well by what's happening downstream of aldo and the receptor. And if there are patients where, despite a high level of aldo, the receptor becomes unresponsive, then that's interesting. Thank you for telling me.
Yeah, maybe we should study that, but it's not so easy. Yeah. So questions now to the study of the New England Journal.
I have a few questions on this New England Journal for Baxdrosselt. You were talking about pathophysiology, Marcus. There's one question that this paper raised. There are a few patients who have hyponatremia with the higher doses of Baxdrosselt. Do you think this is just volume dependent, or do you think it's because aldosterone is lower and there's some interference with the function of the cortical collecting duct? How do you see this? Because you also mentioned hyponatremia as a potential diagnostic criterion to have a suspicion of APA. So how do you see?
I don't think we, in that sort of study, we have a great handle on downstream mechanistic explanations. And probably what I would rather say is that we did look quite closely at comparison of electrolyte shifts in the Brighton study with what we reported in the Pathway 2 trial. And in the Lancet paper there, we plotted the data as frequency plots for each of the drugs. That was a crossover trial, of course, so each patient was their own control. And it's evident that serum sodium, the distribution moves to the left on spironolactone and potassium to the right. And I don't think we felt there was compelling evidence that the aldosynthase inhibitor was having, on average, any different an effect on electrolytes than we'd seen with spironolactone.
Okay. So you think it's just the diuretic effect?
Correct, yes.
Yeah. And so building on what you were just talking about, could you do a sort of head-to-head comparison, spironolactone, Baxdrosselt, in terms of, I mean, for a similar effect on blood pressure, what would be the side effects and the tolerance and the persistence of the patients on the treatment? In other words, what do you think it will replace spironolactone in the next years or not?
Yeah, well, that's a sort of $64,000 question. And of course, as often happens in drug development, the trial won't get done, at least not anytime soon, but it's a head-to-head comparison of the two. So one's left looking at some theoretical arguments for and against, and then trying to pick the fat off the bone of individual trials and see what might be different. From a theoretical point of view, I draw an analogy with the advent of the ARBs on the background of a decade or so of ACE inhibitors. But for years after that, the enthusiasts argued why one class might be more effective than the other. But really, the main advantage of ARBs was a tolerability one. And the 15% or so of patients who developed dry cough on the ACE inhibitor and the 1 or 2% antichronic edema was a non-problem with ARBs. So I think the easiest win for the ASIs will be if there's superior tolerability compared to the side effects that stop people taking higher doses of spironolactone. Will that happen? Well, there were no of off-target side effects in Brighton, and on the theoretical basis, I look at the tissue expression of the mineralocorticoid receptor compared to expression of aldosynthase, and whereas the latter is only expressed in one cell type or one organ, namely the ZG cells of the adrenal, the MR is in almost every tissue, so it's more plausible that it would cause side effects. But that's now got to be demonstrated in trials. The other bit of theoretical/empirical data is that both in mice and humans there are gene knockout models, and those are both concur in saying that whereas you need to knock out both copies of the gene for aldosterone synthase before there's a phenotype and the heterozygote is silent, for the receptor knockout, it's the other way around. There isn't a homozygous knockout because it's fatal, and even the heterozygous knockout has quite a severe phenotype. So whether that will translate into saying that the ASIs are generally better tolerated, I think well, clearly at this stage, that's a hypothesis that has to be tested.
Okay, so in the Brighton study, it was essential resistant hypertension patients. Do you think patients with APAs, with severe APAs, in which we need very high doses of spironolactone to control the disease, they may be controlled only with baxdrostat, or do you think we may need combinations with MRAs or with amiloride? How do you see this?
Yes. So there is a current study, results as yet unknown, in primary aldo looking at dose ranging up to higher dose, up to 8 milligrams. And so that may answer some of the questions you're asking. Regarding combination, I quite commonly use low-dose spiro or pleromone with amiloride, and I think that's very effective in primary aldo. And it's tempting to think that a combination of inhibitor plus receptor blocker would be effective. But again, if we remember what history taught us about combining an ACE and ARB and the on-target trial, then I do think that will happen again soon. I think the concern about excess natriuresis, change in electrolytes, will warn people off going down the combination route.
Thanks a lot.
I would also like to come back one more time to amiloride, because that's available for us right now. And you actually studied that also in pathway 2 and 3, if I remember it right.
Yes,
yeah. On the background on these two studies, so before we get the new drugs, where do you see the place right now in resistant hypertension? When should we actually go for amiloride? You said you sometimes also use the combination of the two of them. So what are your ideas right now? Should we always start with spironolactone and then maybe combine, or would there also be patients in whom you would start right away with amiloride?
That's a great question. And I sometimes say that amiloride is the most underused drug in medicine. I think that if you use it at the right dose, which is probably 10 milligrams for a starter, going up to 20, in pathway 2 was equivalent to 25 and 50 of spironolactone, then it is effective. And in pathway 3, it had a mildly beneficial effect on blood glucose, so that in diabetic patients, it might be particularly attractive. There's no hard evidence to answer your question which order the spironolactone and amiloride would go, but amiloride is a remarkably well-tolerated drug, and it's what is probably lacking is the long-term outcome data that guides so much of what we do in hypertension. But then, of course, we don't have outcome data in hypertension for spironolactone. Its morbidity, mortality wins have been in heart failure. And there are 2 trials in hypertension where amiloride, but at really too low a dose, was combined with hydrochlorothiazide. The MRC hypertension trial in the elderly, and one other where we commented on it in pathway 3. So amiloride, although not on its own, does have some outcome data supporting its use in hypertension. So I would just sum up and say I greatly agree with you that amiloride underused and undervalued, but we're lucky that we can use it. I think many countries, amiloride is no longer available as a single tablet.
Like in Austria and Germany, and I guess also in France. Just one last question on pathway. So you decided first to randomize patients with resistant hypertension on 4 different drugs, and then in the end, everybody went to amiloride, if I remember that again correctly.
Well, it was 3 actives and placebo.
3, sorry. Yeah. So why did you decide to choose this design and not to have the amiloride right at the beginning as one of the 4 drugs to randomize on?
I can still remember the day we discussed this, and the answer was that we felt we needed 12-week cycles because we did a forced dose titration at 6 weeks, and the spironolactone really being a key drug with its very long half-life, and we had to be aware of washout going into the next cycle. The cycle had to be 12 weeks, and then 4 times 12 is 48, and we felt that psychologically asking people to carry a crossover on for more than a year, we risked losing more than we gained. So we viewed the amiloride as a run out rather than making it part of the rotation. We could have done it differently, but that's the answer to your question.
My last question would be again to the future. Now we see 2 or 3 different inhibitors of the synthesis of mineralocorticoids, and there's even another drug class coming, the so-called modulators of the receptors. Is this just that so many different companies are right now interested in this field and develop their own?
You know, it's exciting that we have both the newer non-steroidal antagonists and the inhibitors with several in each class being developed, and hopefully that will rekindle something of the excitement of the 80s and 90s when my career started, coinciding with the advent of ACE inhibitors, ARBs, calcium blockers, and I think when there's more than one in a class, that's a good thing. There are interesting pros and cons for the receptor blockers and inhibitors. A key question is what's going on in the heart, where there's apparently none of the enzyme that breaks cortisol down to cortisone. So are we confident that it is aldosterone that is stimulating the cardiac receptor? In theory, you might say no, and yet I've told you about our data from the MATCH study, where we get these profound changes in CMR and BNP when we take aldosterone out of the system. I hope one day there will be a head-to-head morbidity mortality trial, but I suspect realistically it will be when the drug's been around for a while and an academic funder is able to take that on.
Maybe a last question, because we have a minute or two. You were talking about MRAs. I'd like to have your viewpoint on finerenone. Do you think this is really because it has a more specific effect on extrarenal MR, or do you think it's sort of a low-dose spironolactone? Because you see no blood pressure effect in Fidelio and Figaro. I'd like to have your viewpoint on this.
Yeah. I think until very recently, I was a bit skeptical of the notion that an MRA could have all the benefits without blocking, without leading to a rise in potassium. And the most reasonable explanation was the one you adduce. Some of the other non-steroidal antagonists are claiming falls in blood pressure and being tested in resistant hypertension, and that is possible without so much rise in potassium. As it happens, I was talking to Bert Pitt last week. He came to a grand round I was doing in New York, and he was trying to persuade me that this is due to different distribution of the drugs. I guess it's conceivable that there's more potassium lost than we currently pay attention to through the colon, for instance, and that if the newer drugs don't partition into another compartment that's important, that they wouldn't all have the same effect on potassium. But hypertension doctors are a skeptical lot, and maybe because we're simple, and I would need to see hard evidence to be convinced that the MRAs are doing anything major other than blocking the site of aldosterone stimulation in the distal tubal collecting duct.
Thanks a lot.
Yeah, maybe I can anecdotically add, I tried to treat a patient with hyperaldo with finerenone, and it didn't work. So it has a half-life of 3 hours, and I think it's, as you said, Dominique, a super low dose spiral. And it somehow reminds me on the discussion 20 years before, Gunnar knows is about the vitamin D analogs not having side effects like vitamin D. And at the end of the day, if you interfere with aldo profoundly, you will get all the side effects on the electrolytes. In my view, you get hyperkalemia and so on. So why shouldn't it be like that?
And I mean, there are phase 2 studies done some years ago where they compared the two, and actually the differences on potassium were not so large once finerenone was adequately dosed. So I guess we all remain a little bit skeptical and await the future.
If you have a hyperaldo patient and you cannot block, so to say, the effects of aldosterone with a non-steroidal MRA, I think that's the best explanation. I mean, the hyperaldo overrides all the effects because of this 3-hour half-life and this. It's good for CKD patients, but not for a hyperaldo patient, I think.
So we told you before, we are very, very interested in this field, and you saw we had a couple of very burning questions. So thanks so much for being our guest tonight, but much more thank you for doing all this research in the last decades that have been so important in order to improve both diagnosis and treatment for our patients. And we're positive that we will see much more interesting data from you in the not so far future, and we would be happy to meet you once again in some years to continue this discussion. So have a nice evening in London. Thanks so much once again.
Thank you.